Hello everyone. My name is Dr. Faisal Nagele. I'll be taking you through CNS history taking and neurologic exam. So we'll go through the introduction, systematic symptom review, the neurologic examination, including motor, sensory, reflexes, the red flags. In the introduction, we'll go through the chief complaints, parts of the past medical history, drugs, family social history, and everything else. So there are these cases which you can keep in mind as we go through the history. So just think of what questions you should ask these patients if they were presenting to you. So for history one, we have a male patient saying for a period of 10 minutes, he had his left hand went numb and could not see through his left eye, but that immediately went back to normal. He did not have any similar uh, events following that or prior to that. And a lady telling you she had the worst headache of her life, like a thunderclap headache followed by vomiting and stiff neck. Then we have a student who reports that the teacher noticed them staring into space for a period of time, 10 seconds, without response, no motor movements, no motor or sensory changes, and then has no memory of the event. Number four is a patient who gets a throbbing pain on one side of the head with nausea and sensitivity to light and has a prodrome of flickering zigzag lines prior to the pain. Then we have another patient who has nightly headaches, characterized as excruciating pain behind the right eye, with that eye watering redness. The patient cannot sit still, so very uncomfortable. Sixth patient, 2 weeks ago, the left eye went blurry which was painful on movement. It resolved, but also had other symptoms like weakness. Currently, the legs are heavy and cannot drag the right foot. So just think about what questions you want to ask these patients and try and see what things apply through the presentation. So the common CNS presentations, patients often can present with headaches, and there are varying types of headaches and headache syndromes. Weakness or paralysis, dizziness, vertigo, cognitive decline, seizures, fits, convulsions, whatever they name it, speech difficulties, sensory changes. Patients who present with head injury, patients can present with loss of consciousness, which is caused by a lot of things that are not just CNS. Patients can present with visual disturbance, gait difficulties, and altered consciousness. So any of these can be the the presenting complaint of the patient. If we look at headaches, our objective with a headache, from first assessment of a patient, it's quite difficult to diagnose a patient just without a long history and objective investigations. But to enable us to do those things, we need a proper history that can direct us to what extra questions we need to ask and what investigations we need to do. So just use the Socrates system. So the site where the patient reports the headache, whether it's unilateral, bilateral, and the position on the head, whether it's occipital, frontal, or temporal. The onset can be sudden, gradual, or episodic. So if it's sudden, you want to clearly state the time the symptoms started and how long did that patient take to presentation. So, for instance, the patient developed headache 6 hours ago and has been persistent. Episodes, how many episodes? First of all, when did these episodes start? So maybe they've been having headaches for 3 years. Um, then been having these episodes maybe twice a month. And you want to report also if those episodes are becoming closer in time. So maybe having more episodes over time, 4 episodes in a day, to having 2 episodes, or longer. How long do these episodes also last? So, because you want to see if there have been any changes in the symptoms of this patient. The character, you want to describe this in the patient's words, whether it's pressing, throbbing, stabbing, or band-like, and each of them um, represent a certain type of headache. Radiation, especially when we're dealing with symptoms like meningism, or headaches that result from other conditions such as muscle disorders, nerve disorders. So whether the headache is radiating to the eye, jaw, or shoulder, whatever the headache is associated with, so that's nausea, vomiting, photophobia, phonophobia, aura, fever, or rash. And you want to also, again, classify the association in time. So did the headaches come before these symptoms? Do they always come together? That is the associated symptoms. So, for instance, if a patient has a headache, do they always report this nausea? Has this nausea ever progressed to vomiting? And you want to also look for other symptoms, which we'll discuss. The timing. So when does this headache occur? Is it a morning headache when they wake up? Is it a headache that occurs when the patient has been working all day and they present, usually come maybe in the evening after coming home? Is it a headache that wakes them up at night? Those are all characterizing different types of headaches. What are the exacerbating or relieving factors? So is this headache associated with posture, position of the head, physical activity, Valsalva maneuvers, or any pressure in abdominal or thoracic pressures, relieved by analgesia? Does the patient want to stay in a dark room? Do they not want to be outside and in the morning when the light is rising, when the sun is rising? And the severity, you can use the 0 to 10 scale, and then you can just ask the patient how much this headache has affected their physical activity or their life. There are red flags which require immediate management in headaches. So you want to look for headaches that have symptomatic symptoms, so fever, weight loss, night sweats, in patients who are in an immunocompromised state. So that just indicates systematic dysfunction. Then you have neurologic signs such as focal deficits, papilledema, meningism, and altered consciousness. This can indicate symptoms, the presence of issues like stroke, um, which need to be managed immediately. Sudden or thunderclap, or basically the onset of the headache. Again, did this headache start immediately, suddenly, and the patient presented to the hospital, or did this headache start slowly? How bad did it progress? So from the moment it started to to the point at which it became persistent, how much worse did it get? The age of the patient, new headache development in patients who are older indicates complications like temporal arteritis. You can have strokes if the headache is associated with a position, so worsening or lying down, or steadily worsening over weeks. Headaches that are worsened by Valsalva conditions such as coughing, sneezing, or straining. Postural components in headaches, so low pressure headaches, which are worse on standing, better on lying down. Fundoscopy, when fundoscopy is done, if you can see changes on the retina, so this would indicate raised intracranial pressure and urgent requirement for urgent evaluation. The other presentation is seizures, and there are three things you need to report whenever you're reporting a seizure of whichever kind, whether general tonic-clonic, absence, all of those seizures. They fall into 3 stages. So you have the pre-ictal stage, where the patient can develop certain feelings or signs, such as having visual disturbances, smelling certain things, sensory disturbances, such as tingling sensations. This For patients who've been having convulsions or seizure disorders for a period of time, they understand these symptoms and they kind of become um, accustomed to predicting the oncoming event or seizure event. So you want to ask them if they've been having these signs. And not all patients will always have this kind of thing. At least always ask, but it some patients might even not recognize it and they might think it's associated with something else. Deprivation, patients who say that their seizure or episode of convulsion is associated with certain events such as alcohol, drug use, recent fevers or illnesses, stress, or certain periods of the month during menstruation in females. So during the seizure event or the ictal event, most patients are not aware of what's going on. So a corroborating history is important. You want to ask for the duration of the seizure, the presence of loss of consciousness, eye deviation. So this will be described by whoever was observing the patient. Limb movement for tonic-clonic seizures, tongue biting, urinary or fecal incontinence, and body changes, especially cyanosis, maybe around the lips. After the seizure, you want to ask now the patient now what they feel following the seizure activity or the event. So do they feel confused, and how long do they feel confused? Do they get sort of paralysis? Do they have motor deficits after they wake up, and how long does that last? Do they get headaches, memory of the event? The first, whether this event was the first or recurrent. And again, just as I've said about episodes, if there have been prior episodes, you want to ask how long the episode of, if the seizure was timed and how long that was, then the span between one episode to the other, and if that has changed up to this point. How long does it take for the patient to recover, and if they have received any healthcare before? So have they been on any anticonvulsant medication? Have they been on follow-up for this condition? So patients can tell you that they came in, or you can just hear someone say that the patient came in with loss of consciousness. There's so many things that fall under the realm of loss of consciousness, and other than having neurologic causes of loss of consciousness. We also have cardiovascular compromise that can present with syncope. So there are certain differences. For instance, in syncope, most patients are aware of the that the feeling or the onset of syncope. So they have a way that they'll describe process. Then there's epileptic seizures or seizures. Not all patients have auras, but for a patient who has an aura, they'll be able to describe. For syncope, you will see a patient describe changes in their cardiovascular status. So they've suddenly standing up and feeling dizzy, even losing consciousness, presence of pain, which can increase cardiovascular activity, being in a hot place. Epileptic seizures or seizures in general. For patients who've had prior events, you want to ask them if there is anything that triggers that event. For patients who have syncope, you have changes in color. Epileptic seizures or seizures patients can have cyanosis, or they can be normal. Syncope usually shorter than 30 seconds, so the patient just loses consciousness and comes back. Epileptic seizures can vary. You can have um, changes in motor activity, myoclonic jerks in syncope, but in seizures, depending on the type of seizure you're dealing with, you can have generalized tonic-clonic, you can even have focal or absent seizures. So the point is to just ask the patient exactly what happens to their body when they fall. So Those are things you should ask the patient just to differentiate if they're having a vascular event or they're having seizure activity. So, in the history, if a patient told you that they had a weakness or inability to move certain parts of the body, fingers, toes, the ankle, the wrist, just on any part of the body, first of all, you want to locate that, you want to describe the location of the weakness. Is it one limb? Is it two limbs? Or is it four limbs? If it's one limb, is it a specific part of that limb and what joint is affected? For the weakness, when did it start? Was it sudden onset, for instance, in cases of stroke, or gradual weakness? So the patient tells you that I couldn't move my fingers, then slowly I could move, flex my wrist, then elbow, and now I cannot move my hand completely. And then what limbs are affected? So do you have sort of one leg, one arm, or both arms being affected and the legs being spared? So anytime you describe weakness in one limb, you want to say whether the same situation is present in the contralateral limb. And then if that is also associated with now the lower limbs, for instance. Are there any associated symptoms, especially in motor activity? Have they been having tremors? Have they wasted or seen that the that limb has become wasted? Do they have fasciculations? For patients who have intermittent episodes of weakness, you want to describe exactly when those episodes come. Are they present early in the morning or in the evening, or are they present throughout? And are they associated? Are there any things that make the onset of this weakness worse? Are there any sensory symptoms associated with this motor deficit? Then are there any important positives or negatives in this case? For instance, preceding infections, that is upper respiratory tract infections, gastroenteritis, periods of diarrhea within the last month or so. Then, for a patient who has incontinence, we want to ask them whether there is bladder or bowel incontinence. You want to ask them if they've had any difficulty for patients, for instance, who have GPS for ascending paralysis, if they've had any difficulty in breathing and how they were managed, if they've had any difficulty with speech, swallowing, then you want to always ask about the family history of neuromuscular diseases. For the upper limb, upper motor neuron lesion and lower motor neuron lesion, that's significant in examination. But the important thing here is to ask the patient. So when they could not move that limb, was it just floppy or flaccid, or was it fixed in a certain position? For the reflexes, we'll speak about that going forth. Then in the past medical history, some aspects of this will come to your HPI. You want to characterize any risks that the patient has to developing neurologic events, especially hypertension, diabetes, dyslipidemias for strokes, atrial fibrillation, that is, if they have been previously diagnosed with cardiovascular disorders like AFib, a patient who has a history of a prior stroke or a TIA, patients who have a history of epilepsy, whether it was in their childhood or just any recent history. So we want them to report that. The patient's immune status, whether they have HIV or any other immune compromising condition that that predisposes them to opportunistic infections like tuberculosis, toxoplasmosis, malignancies, especially metastasis or secondary CNS malignancies. You'd be thinking of lung cancers. If it's a lady, gestational trophoblastic neoplasias. So the prior history of diagnosis with cancer, or the presence of other organ dysfunction in a patient who's presenting with the first instance of the condition. Maybe you are diagnosing the patient. So if they have symptoms of chronic liver disease, maybe you start thinking of cancers of the liver, and the patient is concurrently presenting with focal neurologic deficits. For patients who have endocrine causes of neurologic dysfunction, like thyroid disease, so symptoms of hyper or hypothyroidism. Drugs, did the patient take any anticoagulants, antiplatelet agents, and specifically, are they taking those drugs for any condition? So were they being treated for any coagulative disease, or was it used as a prophylactic agent in maybe cardiovascular disease? So the use of aspirin and things like that. Anti-epileptics, when was this patient put on that medication? Is this the first medication that they've been put on for epilepsy? So trying to look for any changes in the drugs that they've been using, and then the compliance to those drugs. Antipsychotics for patients who are on medications as that. So you want to look for any extrapyramidal effects of the antipsychotic drugs, tardive dyskinesia or anything like that. Chronic use of steroids, statins, drugs like metronidazole, isoniazid, especially in in TB patients who are not receiving supplementation of B6, oral contraceptive use, and drugs, or basically an interaction of all these drugs that the patient is taking. For social history, smoking or alcohol use, and if the patient is a chronic alcoholic, you want to ask them about symptoms of Wernicke's encephalopathy, other recreational drugs that the patient is using, exposure to toxins such as lead and things like that, depending on where the patient is working, travel history, so infections such as malaria, giving you cerebral malaria, family history of epilepsy, dementias, and for patients who are having neurodegenerative diseases, you want to look for any support that they have at home, so that when we discharge this patient, how much help will they get, and what risk do they have to developing other conditions. So for instance, these patients are at high risk for falls and things like that, so you will need to have a proper history from the family. So for neurologic examination, as always, our examinations will start with general inspection. So the patient's status before you even speak to them. Then assessing for the level of consciousness, we will use the GCS, posture and position of the patient, if they have any involuntary movements. And when you do speak to them, or when they're speaking to someone else, do they have any abnormalities in speech in terms of initiating speech, the tonus of speech and the smoothness of that speech? Then any obvious physical asymmetry. Higher function, we will test orientation in time, place, and person, do a mini mental exam, memory, long-term and short-term and intermediate, language, attention and calculation, then cranial nerve exam. For motor exam, aside from inspection, we'll do an assessment of tone, power, coordination, reflexes, and look for fasciculation and changes in bulk. Sensory exam, we will assess all components, including light touch, pinprick for pain, light touch for fine, temperature, vibration, and proprioception. If the patient can walk, we will assess their gait, heel to toe Rombax test, heel walking, and toe walking. So for the cranial nerves, it's important to assess all the cranial nerves during your examination and to report any deficits. For cranial nerve number one, we'll use something that is not irritating to the patient. So something like coffee, vanilla, testing each nostril separately and ask the patient to identify smell. So the main thing you're worried about is anosmia. And from your history, you want to always ask if the patient has had any changes in, aside from asking for changes in somatic sensation, you should have asked for changes in smell if the patient had presenting with something pointing to that. For the optic nerve examination, we'll assess the visual acuity, color vision using Ishihara, visual fields using the confrontation test, fundoscopy, and the swinging light test. So the reflex here we are testing is the pupillary reflex, and you need to understand the arc of that reflex. That will include oculomotor nerve. The For cranial nerve 3, we can still, and cranial nerve 2, we can still assess accommodation. So it's important to understand again how that arc works. For cranial nerve 3 and 4 and 6, to save time, you will test them all together. So just from observation, inspecting the pupil size, shape, and symmetry, then and consensual pupillary light reflex, accommodation reflex, eye movement, cranial nerve 3 palsy can present with extraocular symptoms such as ptosis, then pupillary symptoms like dilated pupils, and in movement, you would have an eye that is down and out. Cranial nerve 4, vertical diplopia and downward gaze. Cranial nerve 6 is failure to abduct, so you have a fixed medial gaze. Cranial nerve 5 has a motor and sensory aspect. So we will do the three positions for sensory exam. So that is ophthalmic, maxillary, and mandibular divisions. Of course, we'll assess all components of a sensory exam, light touch, pinprick in all three divisions. Then for motor, you will palpate the masseter and temporalis after telling the patient to clench. You can also ask the patient to open their mouth and observe the deviation of the jaw. Corneal reflex is not usually done in a patient who is conscious, but part of trigeminal nerve examination is the corneal reflex using wisp of cotton. So this will, the ophthalmic division will act as the sensory component and the facial nerve acting as the motor component using through the orbicularis oculi. Then jaw-jack reflex. Cranial nerve 7, there are many ways to assess for the facial nerve, about 7 ways. So you can assess first just by inspection. Inspect the face at rest, then ask the patient to raise their eyes to differentiate between upper and lower motor nerve lesions. Then ask the patient to close their eyes tightly, then try and open them. You can ask the patient to show their teeth or smile. From observation, we are looking for the nasolabial fold, deviation of the mouth. Ask the patient to puff out their cheeks with air and try and push the cheek to see if they can keep the air in their mouth. So the important thing here is for upper motor neuron lesion, the forehead is spared, while in lower motor neuron lesion, all of the face is ipsilateral face is affected. So whether you tell the patient to raise their eyebrows, they will not be able to in lower motor neuron lesion, and they will not be able to wrinkle their forehead. For the vestibulocochlear nerve, we assess the vestibular nerve separately and the cochlear nerve separately. If you have no tuning fork, you can do a gross hearing assessment. So where you rub your finger around the ear and try and ask the patient to what level or to what distance they can stop hearing and compare it with a contralateral ear. But that is a very non-specific assessment. Ryan's test with a 512 tuning fork, you want to assess for air conduction versus bone conduction. Weber's test, then that will be as- assessed using the tuning fork. For when we were assessing the eyes, we could have seen nystagmus, and that can be caused by vestibular component deficits or the cerebellar dysfunction. So that's something you take note of when you're examining the eye and try and associate it with other signs of vestibular nerve deficits. For cranial nerve 9 and 10, so that is going to be the pharynx. As you were speaking to the patient and taking the history of the patient, did that voice sound normal? Did they have any nasal voice, hoarseness, or dysphonia? Then you ask the patient to open their mouth and assess with a torch, and you want to see the arch of the palate. Does it rise? Is it in the midline? Is the uvula in the midline? With a tongue depressor, you want to assess the gag reflex. So that's cranial nerve 9 and 10. Dysphagia. So from your HPI, did the patient present with a history of difficulty in swallowing or choking while swallowing? So this is something you want to look out for. For patients who are coughing, or if you can ask the patient to cough, does it sound normal? Um, Again, when you're looking at the palate, upon the patient opening the mouth, you want to see if the arches of the palate are symmetrical and if there is deviation. Cranial nerve 11 accessory, we will start with inspection again, sternocleidomastoid and trapezius in this case. And you can assess it in two ways by asking the patient to shrug their shoulders and resist force, or turn their head to one side, then try and turn back against resistance, and compare both sides for symmetry. For hypoglossal nerve, this is going to be as part of your assessment of the tongue and mouth. Is the mouth, first of all, is the tongue at the center, lying comfortably, basically resting, or is it deviated to one side or the other? Are there any fasciculations on one side or the other? So on any side of the midline. The tongue tends to deviate towards the side of a lower motor neuron lesion. That's compared to the uvula when you're assessing for cranial nerve 9 and 10, which is usually away from the side that's affected. Then, are there any abnormal movements in the tongue? So, do they have any fasciculations, any maybe movements that result from drugs like antipsychotics? In the motor system examination, we will use the MRC scale. So from a grade of 5 being the normal, 4, the patient can move against some resistance. 3, the patient can move when gravity, against gravity but not resistance. 2, if gravity is eliminated. And 1, if they're just flickers or trace contraction, that has to be intentional, not just tremor. So you ask the patient to move a limb, and if you see that there are some tremors, that's what you're thinking about. Absolutely no movement, that is 0. We have to assess for the tone. So this is done across all limbs. Passively flex or extend the limb, and just see how much resistance there is to movement. So there is spasticity, rigidity, hypotonia. For clonus, that is done at the leg where you try and dorsiflex the heel suddenly and try to see if there is any tremors or basically extension flexion of the ankle joint while following that event. Then we'll do reflexes, mostly the biceps tendon, triceps, ankle jack, but you can also do the brachioradialis. and patellar tendon reflex. So for spasticity, just as an extension of the tone, you have certain changes that you can notice on observation. So you can have a flexed joint, so a persistently flexed joint, or you can have an abduction. If it's in the upper limb, you can have an abducted shoulder, flexed elbow. You can have pronation, flexed wrist, flexed fingers, thumb in palm, clenched fists. And that would apply to any limb. So basically, you have a fixed um, habitus of the limb. For upper motor neuron and lower motor neuron lesions, in upper motor neuron lesions, you have spastic paralysis. In lower motor neuron lesions, you have flaccid paralysis. In upper motor neuron lesions, you have clonus, positive Spobinski, hyperactive deep tendon reflexes, and absence of basically muscle atrophy. But over a long time, there's always disuse atrophy. For flaccid paralysis, you have low motor neuron lesions, muscle wasting, hypotonia, and hyporeflexia. Then you will do your sensory system examination. So hopefully you've carried something like a wisp of cotton. So that will do your light touch. Temperature to assess the spinothalamic pathway. If you have anything cold that you can assess the patient with. For perception, we usually tell the patient to close their eyes, and if the sensory so if you're assessing the leg, for instance, we would maybe assess the big toe bilaterally and maybe ask the patient to say if the toe is pointed up or down, depending on whether they can sense it. Pinprick vibration using a 128 Hz tuning fork this time, and you will put that on a bony prominence. 2-point discrimination if you can do that. The cerebellar examination is shortened by Danish. So D for dysdiadochokinesia, rapid alternating movements of pronation or supination on the palm. And in this case, you're just assessing, first of all, for the ability for the patient to do it. We usually start with the dominant. If the patient is right-handed, we will start with the right hand first and see if the patient can do it. Then can they do it accurately? We're also looking at the speed to which the patient is doing it and to assess for impairment. Then ataxia, if the patient can walk, you're looking for wide-based gait, staggering, reeling gait. There is also truncal ataxia, if you can observe the patient having instability in the trunk or titubations. Nystagmus, so the presence of nystagmus, horizontal nystagmus, with first phase being towards the side of the lesion. Intention tremors in situations such as Parkinson's. Basically, in situations such as Parkinson's, you have resting tremor. So the tremor goes away when the patient is attempting to pick something or to do something. But in cerebellar disorders, you would have the tremor onset being during the initiation of purposeful activity. The presence of slurred speech. So you can ask the patient to say certain things like baby hippopotamus, depending on whatever the patient, whatever the level of education the patient is at. So whatever they can say, constitution, the country's name, things like that. Then hypotonia, on your assessment of tone, that is something you would have noted. If we just to expand on our assessment of the higher cerebral functions, this should have come before everything. We will assess for the GCS of the patient. So you need to know the Glasgow Coma scale. Orientation, ask the patient if they know who they are, what's their name, where they are, and what time or date it is. Attention, so spelling the word the word world forward and backward, serial sevens, which is not always easy for every patient. So you want to do something that the patient can do and not have a false positive. Memory, before you start the exam, you can ask the patient to remember three words, for instance, pen, book, car, and tell them that I will ask you these things in a few minutes. So during, for instance, your sensory examination, you can ask the patient to remind you those three words. That's going to be your short term. For the long term, ask the patient for a specific thing that is general knowledge, so that is known to everyone. So something that most people would know. Ask them maybe who the first president was, and maybe when the constitution was promulgated, things like that. Language. So we assess that in the cerebellar exam, the speech, the tone, whether they can say words, whether they can repeat words. Then if the patient's higher cognitive function, so if they can draw the clock just to see how well they're doing. In other specific examinations, maybe if you have a patient who you suspect has meningeal irritation, you can ask, aside from asking the patient whether they had any neck stiffness or neck pain in the HPI, you can passively flex the neck. So if there's any resistance or pain, that is positive. Carnic sign, flexing the hip and knee, and to see if there is induction of pain, which leads to resistance. Resisting sign, now instead of the hip and knee, you will be flexing the neck and try and induce pain. The presence of photophobia and phonophobia are both positive for meningeal irritation in this type of patients, but of course you have other things that can cause those two things. If jolt accentuation is basically any movements of the head suddenly that can cause pain, or in this case, you're just trying to irritate the meninges. As an extension of the gait examination, maybe as part of your cerebellar exam, in the hemiplegics, you can have circumduction with the arm held flexed with the foot dragging. Cerebellar ataxia, you can have a wide-based gaze, staggering, unsteady patient who is unable to do the tandem walk. Steppage or foot drop in patients who have common peroneal nerve palsy, L4, L5 lesion. Waddling gait in patients who have proximal myopathy, DMD, polymyositis, and hip pathologies. Spastic movements in patients who have bilateral upper motor neuron lesions, spinal cord lesions. In sensory ataxias, you can assess the patient with, if they have a wide-based gait, high stepping, slapping of the feet on the ground, with worsened with closed eyes. You can have Parkinsonian gaits with small shuffling footsteps, stooping of the body, basically the trunk, and reduced arm movements. And then apraxic gait, which is shuffling with magnetic feet. The patient cannot lift the feet off the ground in frontal lobe diseases. So there are red flags, things that you can assess from your history that will indicate that the patient needs some sort of immediate management. So sudden severe headache, worst ever headache. So you can have a differential of subarachnoid hemorrhage that will require imaging. New onset headache with fever and neck stiffness, indicating an infectious process, bacterial meningitis, viral meningitis. You will need imaging, fundoscopy, then an LP. Progressive focal deficits, indicating a growing space occupying lesion, which now indicates that the patient will eventually develop worsened neurologic status. Bilateral or alternating weaknesses, brainstem lesions are a central cause. Papilledema on fundoscopy would indicate increased ICP. Patients who are having a declining GCS. So now we're going to start worrying about the security of our airway. New onset seizures in adults indicates mostly around 30% have a primary or an organic cause. Another spinal cord emergency can be called equine syndrome, where you have saddle anesthesia, bilateral leg weakness, sphincter disturbance. That's a surgical emergency. So for cerebellar and vestibular exam, one needs to be very careful because most of the time those two are confused. So, for instance, Romberg's test tests proprioception and not cerebellar dysfunction. You can have so now you have to differentiate the situation of the patient when the eyes are open or not. Okay, so in neuro exam, our objective is to localize the lesion so that we can guide the sort of management or investigation that will be used later on to prove us to, our lesion or the cause of the problem, the patient's problem. So, first of all, is what the patient's presenting with um, in the brain or in the spinal cord? If it's in the brain, is it the left or right? If it's in the spinal cord, at what level of the spinal cord is that lesion? And you can use that by combining your findings in motor and sensory exam and cognitive or higher function. And so, since we cannot do a full radiologic assessment, always try to localize and be specific to the location of your lesion. Try and look for the red flags to prevent mismanaging a patient with a critical emergency. And then systematic examination for CNS requires a lot of practice and it's easily forgotten over time. So just keep doing it and try and look for patients who have positive signs so that you can see what they look like. Any questions? Okay. Hello, everyone. My name is Dr. Faisal Nagele. I'll be taking you through history and examination in the setting of hematologic disorders. So, depending on the situation that you're in and the patient that you have, generally you want to be able to take history that points to the presence of hematologic conditions. So, basically, a dysfunction of the three cell lines. Then identifying the red flag symptoms that require urgent investigations, especially in hematologic disorders, hematologic emergencies. Then perform and interpret systematic examination, especially in lymph node and abdominal exam in this case. Then recognize peripheral stigmata of hematologic diseases. So the key symptoms that usually a patient can present with that require hematologic workup include fatigue and weakness. So this patient will be telling you that for a period of time, I cannot, I've been feeling like my body is generally weak. I am tired all the time. I cannot work. Then you have a patient who has dyspnea on exertion. In that case, you're already thinking of a cardiovascular disease, but also the vascular component, which is now in this case anemia, can be a cause, which can also progress to cardiac disorders if not treated over a long period of time. Easy bruising or bleeding. This bleeding includes patients who tell you that I have recent onset changes, bleeding from the gums, or epistaxis, or changes in urine color. Maybe they tell you that there is hematuria now. They won't tell you that, but you, of course, they'll tell you there is blood in my urine. Hematochezia, hemoptysis, hematemesis, and changes in menstrual characteristics for female patients. Patients who have recurrent infections, and these infections are not are being treated in Berica, or are not responding to antibiotics, or are at this point the patient is being treated for a chronic infection. So you have a sign of immune dysfunction. Then patients who have unexplained fevers, night sweats, and weight loss. So in hemato-oncology, you want your patient can present with one or all of the cell lines becoming dysfunctional. Basically, a history that shows pancytopenia, bicytopenia, or acytopenia. So when it comes to the red cell, what you can have is just indications or signs of anemia. The patient has anemia that is can be resulting from a tendency to bleed, which means they lose a lot of red blood cells, and they're to the point where their bone marrow cannot really respond and replace adequately, or they are not producing red blood cells, and so they have symptoms of anemia. So you want to know what the duration of onset is. Is it sudden? Is it gradual? Gradual can be both nutritional, where you have iron deficiency, B12 deficiency, or it can just be exhaustion of red cell production. And there's so many things that can cause anemia. So you need to put this patient's anemia in the context of a hemato-oncologic dysfunction, as opposed to maybe someone who has CKD. So the moment you start talking about the red blood cells in your HPI, you want to rule out the presence of white cell dysfunction, the presence of platelet dysfunction, and then you need to talk about the causes of anemia. So either being, what is their diet like? Have they been losing a lot of blood in any form? Maybe they have had trauma, recent surgery. They have other causes of anemia, such as hemoglobinopathies in sickle cell anemia. Maybe they've been on a certain medication. Maybe being a lady, they've had menorrhagia, and they've been losing a lot of blood. So all of those things have to come out clearly as things you're ruling out. And because in your HPI, in this case, you're trying to suggest that the cause of this anemia is hemato-oncologic. So compensatory changes, the patient can present with palpitation, headaches, tinnitus, angina. So they will present with signs of cardiovascular dysfunction. And so in your HPI, you want to also assess the cardiovascular system. In iron deficiency, rule out indicators of iron deficiency such as pica, restless legs. B12 deficiency, you have neurologic symptoms such as numbness, tingling, and unsteady gait. Um, so Then there are the bleeding tendencies, indicating thrombocytopenia or platelet dysfunction of any cause. So, in a patient who you suspect has maybe they're presenting with that anemia, now you need to rule out all the things that can cause to loss that lead to loss of red blood cells. So we can use the bleed mnemonic. So bleeding after dental extraction surgery, maybe even after brushing the teeth. The history of liver disease, chronic liver disease, indicating coagulopathies. That would also be any pre-existing coagulopathy. So they have a family history of coagulation disorders? Has this patient been being treated for coagulation disorders such as hemophilia? Epistaxis, that is nosebleeds lasting longer than 10 minutes. In this case, you want to ask the patient when the onset of this epistaxis was. If it's new onset in an adult, that is something you worry about. If it's something that has been happening since childhood, what are the things that predispose them to nose bleeding? So usually in epistaxis, you can have changes in weather, dry air, the presence of infections such as rhinosinusitis, um, allergies. So the absence of those things with an epistaxis that is occurring with a non-specific precipitating event, that would make you worry about this. Also, when that epistaxis is combined with gum bleeding, easy bruising, you also need to rule out things that that can cause the patient to be in a hypocoagulable state. So the use of aspirin and clopidogrel, so drugs, antibiotics, um, general anticoagulation medication for anything. Maybe they are being treated for DVTs. So, as I said, platelet disorders are associated with mucosal bleeding, gums, nose. Patients can develop menorrhagia, and sometimes the patient can tell you over a period of time they felt like their period has been quite heavy, and you want to quantify that heaviness in terms of maybe the amount of pads they use. And then what can happen is that the patient can lose or develop amenorrhea, especially when now they eventually develop the anemia. So you want to have a very clear assessment of that situation in female patients. In coagulation disorders, you can have deep bleeds, so hematolosis and bleeding in the muscles, especially in patients who have hemophilia. So in this case, at this point, you want to ask the patient if they have either family history or if they've been treated for this previously. Then we come to assessing for leukopenia or leukocytosis, basically white cell dysfunction, because as I said, in your HPI, in a situation where you suspect that the patient is having a hematologic disease, you have to assess for all three. You have to assess all three cells. So the white cell function, patients having being in an immunosuppressed situation where they have recurrent infections, unexplained fevers, and lymphadenopathy. They can have these symptoms, as I said, fever, night sweats, weight loss greater than 10% in 6 months. They can have pruritus. This can be in instances of polycythemia vera, but that's then ask the patient if they have felt that there have been any swellings in the neck, axilla, or groin, and you will examine for that later on for lymphadenopathy. Early satiety, epigastric discomfort in splenomegaly, hepatomegaly. You can also have bone pain in patients who have, for instance, leukemias. Then for family history, as I said, you want to ask for bleeding tendencies in hereditary hemochromatosis, sickle cell trait, thalassemia. You also want to ask them for any patient any person in the family who's been treated for hematologic malignancies. So in this case, you're trying to ask for something like, well, you can't ask directly for Philadelphia chromosome, but then you want to see for hereditary hematologic cancers. Patients who have alcohol use can have something like B12 deficiency. Dietary restrictions, meat and iron, occupational exposures to things that can cause cancer, so benzene, radiation. Certain diseases, infections like leishmaniasis, malaria, can present with splenomegaly and bone marrow. Can look like the patient has bone marrow dysfunction. So on physical examination, on general exam, we'll look for pallor, conjunctival pallor in the palms, jaundice, TKI, polynychia, and glossitis. Pallor in anemia, jaundice can be hemolytic. Thrombocytopenia giving you the easy bruising in what the patient will describe as easy bruising, but you will see TKA, purpura, ecchymosis. Cholinergia in chronic iron deficiency, and glossitis in iron deficiency, B12 deficiency, or folate deficiency. Assess the lymph nodes in these patients. So neck, so that's axilla, neck, and groin. Supraclavicular lymph nodes, Virchow's lymph node can be associated with gastric nodes. Epitrochlear nodes are usually forgotten, so you want to assess that. Axillary and lymph nodes around the mandible. When you do find these lymph nodes, you have to describe the size, the consistency, whether this lymph node is mobile or fixed to the skin or underlying tissue, where there's any associated tenderness. And then when there are multiple matted nodes, for instance, in tuberculosis, then you have to do an abdominal examination in these patients because of splenomegaly or hepatomegaly. In the spleen, we have to assess for splenomegaly, and this is done by assessing by deep palpation from the right lower quadrant, progressively towards the left subcostal area. We want to assess the patient in a supine position, palpate the patient using the radial border of your hand, and try and palpate as the patient expires and inspires, so that you can use the diaphragm to push the spleen down. In this case, when you do find a splenomegaly, you have to assess for, first of all, the surface of the spleen. You have to estimate the size of the spleen to see whether there is moderate, severe, mild, moderate, or severe splenomegaly. And that there are so many grading systems. Then you want to assess the age of the spleen. Can you go above it just to differentiate it from any other malignancy? Mass that can be present in that position. So for the spleen, you can never really go above it. It has a smooth edge, a smooth surface, and it has a notch on the medial aspect. So you will also try to palpate for that notch on the medial aspect. If you have not yet palpated for a spleen at the point at which the patient, you are maybe at the subcostal area on the left side, you want to tell the patient to take a deep breath and try and see if the tip of the spleen is going to hit your finger. For the liver, aside from looking for for hepatomegaly in the systemic exam, you can also look for generalized stigmata, basically stigmata of chronic liver disease. So these things can cause chronic liver disease associated with clotting disorders. So you just want to rule out the presence of this condition, the presence of spider angiomas, palmaerythema, gynecomastia, hepatomedusae, aceraxis. All those things indicate chronic liver disease. And since we are still considering the possibility that the anemia or this condition can be caused by nutritional factors like B12, or are being caused by chronic liver disease, which can be associated with encephalopathy, you will have to do a musculoskeletal or a neurologic exam to look for things like for on the skin, we look for spidergiomas and palmar erythema. Generally, we will look for gynecomastia and testicular atrophy in liver disease. Caput medusa, I think I've repeated this slide, but for the neurologic exam, uh, you want to look for signs of spinal uh, degeneration in B12 deficiency. So you will have to do a motor exam, a sensory exam, an assessment of the deep tendon reflexes. For encephalopathies like Wernicke's encephalopathy, you have to do the neurologic exam, assess the higher function of the patient, and try and find your findings through that. But in hematologic disorders, most of your clinical findings are going to be from your HPI. So the moment you have a patient whom you suspect has a hematologic disorder, first of all, what is their presenting complaint? Maybe they presented with a bleeding tendency. So they had a nosebleed for maybe 20 minutes and they were rushed to the hospital. You will try and see if there are any other bleeding tendencies or any other signs of bleeding tendencies in this patient. So do they bleed from anywhere else? Do they have easy bruising? And some patients will notice it, some will not. So you will try and look for it in your exam. Then always, anytime you assess for one cell group, try and assess for the others. So look for signs of anemia. Look for signs of white cell dysfunction. So recurrent infections, recurrent treatment with antibiotics, recurrent hospitalization, and also at that same time rule out other causes of immune suppression, such as HIV. And the presence of things like you always have to talk about the presence of risk factors. So either the family history, exposure to toxins, conditions like HIV that can predispose you to lymphomas. All of those things have to come out in your HPI. So in this type of patients, the HPI tends to be quite long as you find yourself going through most of the systems, and the examination tends to be quite deep as you will do a CVS exam, you'll do a respiratory exam, do an abdominal exam. All of those things are important so that now we can direct further investigation in this patient. Thank you. We'll be joined by the next presenter, Dr. Gisore, who will go through renal and respiratory history.
Hi everyone, I hope I'm audible. I'm Bisoda Morara. I'm a recent graduate, graduated last year with a bachelor in medicine and surgery. Today, I have the privilege of taking you through the renal history and the respiratory history. So I want you to do that by just taking like kind of examples. I have used AI to help me, so I'm using Notebook to learn. It's kind of like a research assistant. So it can help you create flashcards. It can help you create infographics such as the one presented and the like. So to discuss a renal history, I'd want us to go through chronic kidney disease. I believe my group of students, we've had this talk before. So maybe to just be more of a recap. So, right. I when you're talking about any history, I intend to just use 40 minutes, it being a Sunday evening. So, 20 minutes for CKD and maybe 20 minutes for RS history. So, when you're talking about history, basically the most important thing a history tries to show you, it's kind of like the first step in any form of management of a patient. It's always step number one. Number two, for you to come up with a diagnosis of a patient, the history is kind of like the core of everything that is doing. So, knowing how to take a history and having a well-structured history is kind of cornerstone of all medicine and all surgical surgery. That's where it all starts. Now, when you look at a history, I like breaking down a history into five segments. So, history usually has symptoms. A history has something called important positives and important negatives. So, for the important positives and important negatives, we can all just shell it into one big group called associated factors. And then after that, we can now talk about risk factors and lastly about severity. That is in the HPI segment. I think I just condensed it into the HPI, but remember the history usually has the biodata, the presenting complaints, the history of presenting illness, and then from the history of presenting illness, you have the past medical history. From the past medical history, you have the family social, and then you have the review of systems, and lastly, the summary. So what I was trying to say, I've just really dived into the history of presenting illness because that is basically the bread and butter of what we're doing here when you're trying to come up with a diagnosis. Now, I repeat again. So every HPI has usually five five segments, more or less. So we have describing the description of the symptoms. We have the important positives, important negatives, which can just generally be termed as the associated factors. And then after that, you usually have the risk factors and the severity. So when you look at that, every time you follow that template, you find that you can always clerk anything in detail, and you can get a clear story from a patient, and you can elicit any disease. Now, I do not intend to go over the generalization of any history. I want us to focus mostly on the renal history. Uh, so when we start, we can use time to kind of classify renal diseases, and we can start by talking about acute kidney injury, and we can talk about chronic. So anytime you hear something of acute, chronic, and then there's also subacute. So acute just means something that happened sudden, something that has just happened a day ago, 2 days ago, maybe a week ago. And then chronic is something that has been inherent, something that has been there with the patient has been living with for quite a while. And usually the cutoff for most of these things is usually either 3 months on one condition, or it could either be 6 months on other conditions. So that's what we mean. And then subacute now in all those definitions usually come in between acute and chronic. Yes. So when you're talking about acute kidney injury, is we're talking about the change in kidney function that has happened abruptly. Okay, and the causes could either be pre-renal, renal, and post-renal. So when you're talking about pre-renal, what comes before the kidney is usually the vessels. Yeah, so we're talking about problems with regards to supply of just a minute. Okay. with supply to the blood supply to the kidney. So anything that is affecting the renal blood supply will cause pre-renal acute kidney injury. And then the renal, we're talking about the intrinsic. So in anatomy, remember, when you're talking about any type of organ, usually have the stroma and the parenchyma. So the stroma is usually kind of like the connective tissue and the blood cells that are found there and the lymphatic cells that are found there and the lymphatic supply. That is the stroma. And then the parenchyma is basically the core of the functionality of the organ. So in the parenchyma of the kidney, we'll be talking about the nephrons here. So you find that renal acute kidney injury is things intrinsic to the kidney, things affecting the nephrons, things that are causing nephrotoxicity, be it drugs, be it another condition, or things also affecting the stroma could also cause a renal acute kidney injury. And then lastly, you have postrenal. So after the fact of the kidney, so you have things causing obstructive uropathy. So you have something obstructing the tubes, kind of like the plumbing, all the way from the renal pelvis all the way to the urethra. So anything that causes obstruction there, or anything that will cause blockages in that part, will cause postrenal acute kidney injury. And now that is basically talking about acute kidney injury. Acute kidney injury is usually a bit harder to understand because, as I tell my students, you cannot read it as in you cannot use it as a good guide to read on renal history taking or the renal conditions because AKI happens anywhere. It can happen in any part of the hospital. It can be in the surgical wards. It could be in the medical wards. It could even be a mom who's just given birth and she's bled out and the kidneys take the hit, so it will be pre-renal. It could be someone who's undergoing surgery and because they're bleeding a lot, they get an AKI right there and then, and something needs to be done. So AKI is kind of diffuse, yeah. So always remember, an AKI is kind of like something showing a deeper issue. So you need to find the cause of the AKI. But now when we come to chronic kidney disease, is something that is either affecting the structure of the kidney and the functionality of the kidney. So the best way to remember chronic kidney disease is in the definition. Number one, the timing of the definition is important. Number two, remember it's something that is affecting the structure or the function or even both. That is chronic kidney disease. Sawa. Timing is important. Remember acute, subacute, and chronic. And chronic is something in the far end, something that has been with the patient for quite a while. So is it 3 months? Is it 6 months? Is it 1 year? Is it 5 years? Okay, right. And then the structure. So what structural issues can come about, right? So remember you have the glomerulopathies, yeah, in the glomerulus, things that are affecting the glomerulus, things that are affecting the nephrons, and also things that are affecting the tubes. I like to call them tubes, the urinary system, yeah, all the way from the pelvis again to the urethra. Right. So the question will be now, what are the causes? What are the etiologies of chronic kidney disease? And I'd want you to just remember three. And the first one is usually hypertension. The second one is diabetes. And the fourth one is the glomerulonephritis. So hypertension, diabetes, and the glomerulonephritis. So these conditions are usually kind of the top three. You can also add there are viral causes and the other causes, but I just want you to remember the top three: hypertension, diabetes, and the glomerulopathies, the glomerulonephritis. Right. I, um. Then, to understand chronic kidney disease, I want you to understand the functions of the kidney. So, when you're looking at this infographic here, the mnemonic is a wet bed, right down here. That is like the mnemonic of what the kidney does. So you have water balance, electrolyte balance, acid base balance, blood pressure control. Remember, the kidney is the number one controller of BP in your body. And then you have vitamin D metabolism, erythropoietin, and toxin removal. So for erythropoietin, remember all chronic kidney disease patients will have a form of anemia, and it's usually normocytic, normochromic anemia. Erythropoietin is a hormone that kind of boosts the production of red blood cells. And then in vitamin D metabolism, meaning anytime you see a chronic kidney disease patient, they will have problems with their bonium calcium metabolism. So their bone chemistry will be haphazard, and they will get something called renal osteodystrophy. The other thing is, anytime you see a chronic kidney disease patient and you look at the files, their blood pressure is always raised. So this is kind of a vicious cycle where we're talking about in the risk factors for chronic kidney disease, we have hypertension. And we're also saying that chronic kidney disease in itself also causes hypertension. So it's like a synergistic thing that's going on there. So it's a vicious cycle. And then now for the acid-base balance, remember we had two physiological processes. We had the kidneys working for the metabolic side and the lungs working for the respiratory side. So for the metabolic, you can either have acidosis, whereby you're having the kidneys holding back a lot of hydrogen ions, or the kidney losing a lot of bicarbonate ion. And then you can have the fact that in the respiratory acidosis or respiratory alkalosis, you have the kidney working as the compensatory mechanism. So if the kidney is having a problem, then you find that this cannot work well. Okay? So now, why am I telling you all of this? Why is all this important? First two questions I want you to always remember. The first thing is, do all chronic kidney disease patients get affected in this? How many are there? All these 7 conditions. Are they always there in the 7? Then the other question is, are all chronic kidney disease patients the same? The answer to the second question is no. Not all chronic kidney disease patients are the same. They're usually classified in stages. So the staging system is the KDIGO. So in KDIGO, it stages them from stage 1 to stage 5, right? And then you usually have a stage 3A and stage 3B. If you check on that staging, you find that they usually look into 2 things, not just one. They look at after the albumin. They look out for the glomerular GFR, the glomerular filtration rate, and then lastly they risk stratify them after pitting in the albuminuria and the GFR together to give us the 5 stages. Most people forget the albuminuria, and they also forget the risk stratification. So when you check the KDIGO, always remember that we are checking on 3 things. The first one being albuminuria, the next one being the GFR, and then the most important is that we start risk stratifying the patients, meaning that CKD patients are not the same. They are risk stratified. So we can have a stage 1 patient being very different from a stage 5 patient. Then the first question was, do they have problems in all these 7 symptoms? No. The answer is no. So you find that water balance and electrolyte balance are the first one to always get obtunded. Okay? And then you find that the hormonal side and the metabolic side usually now comes in the later stages of chronic kidney disease when the glomerular filtration rate is starting to go below 60. This is when these other conditions start presenting. Right. We move on. And then now we check on CKD. When you start looking at the signs and symptoms of CKD, you might get flustered, frustrated, because it presents as anything really. It can come in any form and any in any system. It can present as anything it really wants to. So the best way to remember is using this await bed mnemonic. Remember that it has a role in water balance. So if the water balance is broken, what happens? They become edematous. And what is the difference between the edema that forms in renal patients and the edema that comes in heart cardiovascular patients? The thing is the severity. Which one is more severe? The renal patients. Yeah, they become more edematous, something that is called anasaka. Okay, they have early morning facial puffiness. Even the upper limbs are swollen. They get ascites. The lower limbs are very markedly swollen. And then when we look at the electrolyte balance, what do we find there? We usually now find that they can have derangements in their sodium. They can have derangements in their potassium. They can have derangements even in calcium and the like because of vitamin D metabolism. So that is also very important to remember. So they can come in hyponatremia. They can come in either hyperkalemia or hypokalemia. Then in acid-base balance. So in acid-base balance, because this system is affected, we find that these patients always come in an inherent metabolic acidotic state. Sawa. And then for BP, we've said these patients are always hypertensive. Most often than not. Let me not say always because like that is not good science. And then vitamin D metabolism. So in vitamin D metabolism, remember vitamin D facilitates parathyroid hormone. Because it facilitates parathyroid hormone, the question will be, what does parathyroid hormone do? Parathyroid hormone kind of mobilizes calcium. Okay, how does it mobilize calcium? It gets it from the bone, number one. And then number two, it ensures that in the kidney, there is reabsorption of calcium. And then number three, through vitamin D in the intestines, there is reabsorption of calcium. So it mobilizes calcium in the body. So if you don't have vitamin D, then parathyroid hormone does not have its best helper. It does not have its facilitator. So there will be problems in calcium. And if there's problems in calcium, almost always your bones will be affected. So you get things called renal osteodystrophy. And then in erythropoietin. In erythropoietin, I like using the analogy of the 80s. So the 80s, there was a lot of disco music, yeah, the funk music. And in the funk music, um, the lights, the big afros, the dancing, you get the vibe, Thriller, that's when Thriller was actually produced. And in the 80s as well, we usually had the cocaine epidemic. So I usually say that the cocaine epidemic was kind of like the booster of the music industry. But that's not proven or anything. So in that same case, erythropoietin is the booster of red blood cells. And what is the most important thing about red blood cells? It's the hemoglobin. So if you don't have erythropoietin, you don't have the thing that is boosting red blood cells. What inherently happens? Then you get an anemia. Yes. And then you have toxin removal. And the most important toxin we're talking about here is urea. And in urea now, this is when you're now in end stage. When the kidneys are no longer working, you can even get an encephalopathy. They can come in hematemesis. Uremia presents as anything. I don't want us to spend time going through all the symptoms of uremia. Yes, that's how you go through the signs and symptoms of chronic kidney disease. I hope that is well managed, understood. And then now, the last thing I'd want to talk so that we go now to the history is the management of chronic kidney disease. In the management of chronic kidney disease, the best management is to always stop the aggressor. So if hypertension was the aggressor, treat the hypertension. If the sugars were the problem in diabetes, then treat the aggressor, which is the sugars. Ensure proper sugar control. But it does not end there. Remember, when you are doing, I think this is taught in pathologists usually like this topic, but I think also in physiology is there and also in anatomy, where we talk about different types of cells. You remember we have the rapidly regenerating cells, and then we have the cells such as the muscle cell and the neurons, which are permanent cells, meaning they cannot undergo division after they have finally differentiated into the complete cell. They stay that. So if you lose that cell, that is it. Same as the nephron. So if you lose the nephrons, that's it. we have nothing we are working with. Okay, so there is more into the management of chronic kidney disease. So the question will be, how will I remember all of this? Remember the functions of the kidney. So in water balance and in electrolyte balance, there will be a case of trying to manage someone who's edematous, or someone whose lungs are drowning in their own fluids in the form of pulmonary edema. In blood pressure control, may they be on antihypertensives. In vitamin D metabolism, then you have to give them analogs of vitamin D, right? And what are the analogs of vitamin D? Remember, vitamin D, the metabolism usually starts in the liver, finishes in the kidney. So there are different analogs of vitamin D. Would you want to give them the inactivated form of vitamin D? Will that really be helpful? Not really, because the activation happens in the kidney. It won't be helpful. So you need to give them already active vitamin D. Then, importantly to remember is that vitamin D plays an important role in your immunity. At this particular juncture, always remember that CKD patients are immunosuppressed. Be that as it is, any immunosuppressed patient, what do you want to do? You want to give them vaccines for the common conditions that they may encounter. And then number two, never forget nutrition. We are what we eat, so they have to be in a balanced diet. And in the balanced diet is the big three: vitamins, carbohydrates, and proteins, as well as supplementation of the minerals and the vitamins that they may be losing. And then lastly, erythropoietin. For erythropoietin, the answer is simple. Give them an analog of erythropoietin and they become well. Now, in the toxin removal, that is where we have to talk about this. And I'm talking about this because there's no other place we can talk about it in this. Is when we're talking about renal replacement therapy. And in renal replacement therapy, we usually have dialysis and we usually have transplant. The dialysis. What are the indications of dialysis? The mnemonic is RAEOO. RAEOO. So there is acidosis, and then there's the ingestion of toxins, and then there is the E is electrolyte imbalance, and then there is intractable fluid overload, and then there is uremia in U. So always remember that in RAEOO. Yet again, management, the cornerstone is removal of the aggravator. But it does not end there. You always have to remember the functions of the kidney. Yes. Now, why am I telling you all of this? It's just kind of like a rundown on what CKD is, what it does, how it affects the patients. Then to you now, someone who's going to go into the renal ward, who's going to be taking a history in the CKD patient. Always be objective in what you are doing. Remember, in CKD is a chronic condition. So you find that maybe these patients have been in healthcare for far too long. So you are not getting the histories at that particular point. That is something I have to highlight. Okay. And then there is the case where you are getting these cases earlier on, and you are the first person to say that maybe this patient is getting a nephrotic syndrome or a nephritic syndrome. So I need to know the presentation of a nephrotic syndrome or a nephritic syndrome. But in most cases in CKD, you find patients who are already in the system, patients who have already been seen in healthcare. And if for such patients, it's always good to be objective, and it's always good to ask the important questions. You need to tell us that this patient is a non-chronic kidney disease patient, and then you tell us for how long has this patient have they had this condition. Okay, so they are non-chronic kidney disease patient for 5 years, CKD patient for 2 years, CKD patient for 3 months, for 6 months. It is very important. And then you ask the pertinent question on how this disease has been managed over time. So where do they go for the clinics? Which drugs are they on? Which supplements are they on? Remember the management that we have been doing. Have they been using those drugs and supplements religiously as they are supposed to do? And then any complication that has happened during this course of treatment. So maybe someone has had uremia 3 times in the last year. So it's something important to know because unfortunately, misery usually strikes the same place more often than not. So there's the off chance that it's just not well managed CKD. That's why they're always presenting with these complications. So if you tell us early, we already know. So for such patients, do not waste so much time in trying to figure out what caused the CKD. Just focus on telling us how this CKD has been managed. And then importantly, tell us why they are in hospital. So why would a patient with a 5-year thing be presenting in hospital? Number one, it could be because they are coming in for their next round of dialysis. Number two, it could be because they're coming in because of the complications of chronic kidney disease. So what are the complications of chronic kidney disease? Could you get a patient who's admitted because they were in severe metabolic acidosis? Could you get a patient who's been admitted because it's a case of uremia? It's a case of intractable hypertension to the extent that it's become malignant hypertension. So this is what is presenting the patient to the hospital, the complications of the CKD. So the first one we were saying, they were coming to hospital as normal management, that waliambiwa ama they have been told by their previous doctor that at this particular day, you need to come to the hospital for follow-up. Okay, that is one time the patient will come to hospital. The other time is when they are coming in because of a complication. That is another time the patient will be coming to hospital. And then there is the unknown CKD patient, the one who did not know that they had CKD. That's also another patient. And now in this patient, remember the big three: hypertension, diabetes, and the glomerulonephritis. So the glomeruloneuropathies, I'm sorry, my local tongue does not allow me to say that thing quite a number of times. So always keep it in mind. And if you do keep it in mind, it makes your work easier. So you'll clerk for hypertension. So what type of hypertensive patient will present with CKD? Probably is a patient who has not been serious with taking their drugs, right? It could be diabetes. What type of a diabetic patient will be getting chronic kidney disease? Maybe not so well managed diabetes. In the glomerulonephritis, what causes glomerulonephritis? Remember the nephritic syndrome and the nephrotic syndrome. Then take it on from there. That is how I always want you to remember it. That anytime you get or suspect a CKD, ensure you tell us about the management. And then ask yourself, what type of patient is this from what they're telling me? Then after you have categorized the patient, you can now start taking the presenting complaints in a much more smarter and manner. And then now, if you're taking in the example for this unknown patient who did not know they had CKD, remember in the HPI, the symptoms are very important. So what are the symptoms of CKD? A wet bed. They will have a problem with water balance. They will swell everywhere. We have gone through this, a wet bed. I don't want to repeat it. And then you will go to the associated, the important positives and negatives. So what are the important positives and negatives? The important positives are questions you asked and you find that they were positive. So, for example, you asked about symptoms pointing towards anemia. The patient did not tell you that they were fatigued, easily fatigued, that they had people had noticed that they had become pale. They did not tell you that when they climb stairs, they start getting breathless. These were questions you, as the healthcare worker, asked, and they became important and they were positive. So you write them down. Then the important negatives are questions you are suspecting that you will find, but you did not find. You still detail them because if you did not detail your work, you did not do it. Hope that is important. That is well explained. And then After that, you move on to the risk factors. Again, what are the risk factors for chronic kidney disease? The big three: hypertension, diabetes, and the glomerulonephritis. In the glomerulonephritis, what causes glomerulonephritis? Remember, there is nephritic syndrome and nephrotic syndrome. In nephritic syndrome, you usually have post-streptococcal GN, you usually have the viral causes, and then you can even have problems with the SLE, the autoimmune conditions. And then in the nephrotic syndrome, remember, the different pathologies, yeah, the focal segmental, the membranous, and the like, and how do they present like, okay? And then you move on to the severity. Now, for the severity, I do not mean the visual analog scale. What I mean is you ask the patient, maybe, for example, what is your occupation? When is the last time you went to work? How are you paying for your medication? Who has been taking care of you, so that you know how severe this disease is and how will you help this patient going forward. And with that, maybe that is the only thing I would add for chronic kidney disease and the stages. It's such a big topic, and I've tried to compress it. And I know you guys have an exam. I hope I've been able to unclog some things. Maybe there was something that you did not understand well. Now, lastly, I want us to do a quick rundown on the rest one. Again, this is a notebook. Really, really good. I'm still trying to najaribu to market it, because I think it can be a helpful tool for your revision, even as you're going to do your end of year and your end of rotation. Right. I don't want to use this. I think now, let's say now I wanted to talk about so I just come here, and then for pulmonary tuberculosis, which I think is the best one, the best template we can use to talk about a respiratory history. And then we form an infographic so that we have something to guide us. Again, I repeat, when you're looking at a HPI, what are the components of a HPI? Again, you have to give us the symptoms, the associated factors, which are the important positives and the important negatives. And then you have the risk factors, and you have finally the severity. Okay? But now, in the respiratory history, if you look at where you are seated at this particular juncture, what you are doing, there are only two portals of entry into your body. Is either something you ingested orally or something you're breathing. That is mostly the two common forms of things getting into your body. What am I trying to put across here? You find that now in respiratory, the risk factors is something that needs to be taken quite with such precision, with such delicacy, because it really, really guides us on what is going on. Most often than not, just a minute. So you find that the risk factors are very important, very, very important in the respiratory, and they are limitless. You can never exhaust all the risk factors in respiratory history, but there are some pertinent ones. There are some that will always have to be there. Yes. And then the other thing is, under the risk factors in respiratory history, I always want you to remember, always, in any form of respiratory history, be it you've gotten a patient with with a pneumonia, be it you've gotten a patient with tension pneumothorax, you've gotten a patient with a collapsed lung, you've gotten a patient with interstitial lung disease, you've gotten a patient with COPD, always have a section whereby you are talking about the occupation of that patient. And occupation does not mean asking the patient what they do for work. Occupation means you need to kind of catalog every type of work this patient has been doing since they started working, so that we can follow up again with the risk factors and all the exposures this patient has been getting over time. I hope that is well understood. Yeah. Now, we take an example of TB. Now, in TB, we can go, you guys have done TB, I think, since second year, when it was first introduced, I think, in microbiology. And then after getting introduced into microbiology, you also covered the pathology section of tuberculosis. And then you will also cover the now, how does it affect patients, how like the clinical doctors affect it. So you can find tuberculosis in the surgical ward, you can find tuberculosis in the medical wards, you can find it anywhere. So it's one of those conditions where you read it all through your medical school life. You being in the tropics, TB is one of those diseases. Okay, so a TB patient, and in this time, let me just cap myself so that I don't keep you here for long. I want to just talk about pulmonary tuberculosis. So what type of patient can I get that they have TB? Number one, I can get a newly diagnosed tuberculosis patient, a patient who has had the symptoms and they came to a healthcare facility and they have been diagnosed with tuberculosis. Number two, we can get a patient who has already been diagnosed with TB and they are coming in for follow-up, for management of the tuberculosis. Number three, we can get a patient who is suffering from the complications of TB. So either the TB was cured and it caused a form of complication such as interstitial lung fibrosis, or the TB was not cured and they went into MDR or XDR TB, or the TB disseminated in the form of miliary TB and now they have tuberculosis everywhere. It's disseminated form of tuberculosis. Just a minute. Yeah. So we start with the newly diagnosed tuberculosis patient. And the newly diagnosed tuberculosis patient, when you're looking at the symptoms really don't change. It's a chronic cough. It is usually productive. And then please describe the type of sputum that there is. Did it have blood? Was it green? Was it rusty colored? And if it's rusty colored, what could it be? They can come in with the B symptoms: fever, night sweats, weight loss. In the weight loss, please try and quantify the amount of weight that they have lost. Okay, they can come in with an asymmetric quiz. Like every time they sleep, they have this asymmetric quiz that is coming. In the cough, please be detailed with the cough. They can come in with in respiratory distress. Okay, that is the newly diagnosed patient. And then what will be the risk factors for a TB? So for TB, it will be contact with someone with similar symptoms, not contact with someone who had TB. Don't keep it to the patient for them to diagnose someone who had TB. It's easier to ask a patient if they were in contact with someone who presented with a similar condition. Okay, that is one risk factor. Occupation is important. Remember, in the occupation, there are people who are at more risk of getting tuberculosis. Think about it like this. Think about someone like a tout, a conductor. Look at the environment that they work in. Look at a healthcare worker, a nurse, the clinical officers, the doctors. I think they're at more risk of getting TB. So again, the occupation comes in handy. You have to ask about it. Yeah, maybe other occupations whereby they always work in crowded rooms and they're always in confined, not well ventilated rooms. They could be at risk of getting tuberculosis. People who work in labs, the microbiologists and they're always handling this specimen. Maybe they did not handle it well, right? And then when we are here when you're talking about that, the risk factors, remember now I was talking about the common risk factors that you always cut across. The history of smoking. Smoking will always be there. So in smoking, we can just finish now. Remember, we want to hear about their debut when they started smoking, and then we want to hear the number of pack years. So always calculate pack years. And pack years is simple, okay? It's X over Daniel. I think Daniel has 26. So it's X over 20 times the number of years that they've been smoking. Okay? So you ask the patient, how many cigarettes do you take? They say, I burn through 2 packs every day. So those are 40 cigarettes. So it's 40 over 20 times 5 years. The other will be like, doc, I only smoke when I'm going out. So I only take like 4 cigs. So it will be 4 over 20 times the number of years. That is very, very important. I repeat, the debut and the number of pack years. Okay? And sometimes always tell us, what are they smoking? You know, there are also people who will say that I don't smoke cigarettes, but I smoke marijuana. So ensure you ask about everything. I don't smoke cigarettes, but I vape. Okay? So be very specific on what you're asking. Right. And then there is alcohol use. Alcohol use in this sense, remember, chronic alcohol use is kind of, think of any alcoholic, how they let go of themselves, how they're always dirty, how they're always getting into this, they're not taking care of themselves. It's an immunosuppressive state. They don't even eat well. So at the end of the day, alcohol is still a risk factor for tuberculosis. And then again, we're in the tropics, and one of the biggest conditions we have is HIV. So ensure you've asked someone about their serostatus, and ensure you've asked it well, and ensure you have been firm so that they know what you're asking, because some patients might not be willing to give that information easily. Okay? And if you do suspect and they're not willing, just remember, how will you take someone's serostatus, the risk factors for HIV. Maybe those ones you need to also cover them. Right. And then lastly, the severity. And in the severity, we do not mean the visual analog scale. We mean, how has the patient been faring on? What was the patient's baseline, and how are they operating since they got this disease compared to their normal baseline? That is what I mean. So that is the easiest way you can get TB, a newly diagnosed patient. Number two, you can get a patient who's already had TB. Now, for a patient who has already had TB, that is a chronic patient. That is a patient, again, just like in CKD, they're already in the system. They already know what is happening. So be very specific on what you are supposed to ask and how you're supposed to ask, okay? So number one, when were they diagnosed? Where were they diagnosed? Where do they go for the clinic appointments? When is the last time they went for their clinics? And then, are they on anti-TB drugs? Okay? And then, if they're on anti-TB drugs, you ask them about their compliance on the anti-TB drugs. Then, these patients, they are patients who could be on the system. Remember, when they were diagnosed, TB does not have one particular way of diagnosing. The gold standard, the gold standard is the culture, the Lowenstein Janssen culture. The most commonly used, because of its rapid turnaround time in Kenya, is the Gene Expert. Then you can also use imaging, so you can take a chest X-ray, look at it and be like, I think this patient has tuberculosis. You can also use the immunological, the serological test. And the question will be, do you think serological tests are used in Kenya to diagnose TB? They are not used because of our BCG immunization. So they will be null and void. Okay? So even when you're asking about when they were diagnosed, remember, tell us, what was the mode of diagnosis? Was it through Gene Expert? Was it through culture? Was it through imaging? Was it through the signs and symptoms? Was it through as like the tuberculin skin testing, maybe they are coming from abroad or something. Iron, that is important. And then these patients, as they are going in, when they are being given the anti-TB drugs, these drugs are expected to work over time. Remember, there is the 2 months intensive phase, and then there is the 4 month consolidation phase, right? So in this, please remember, when you're doing this at this time, these patients still get tested again and again. They can be they can be certified like they have seroconverted, so they're not showing any more TB, the mycobacterium on the microscope, okay? And even then, when they are certified TB drug free, TB free, the question will be, how are they certified TB free? So let us repeat again for the non-TB patient. Tell us when they were diagnosed. Tell us which modality was used to diagnose them. And then tell us where they were diagnosed and where they go for clinic. Tell us if they're on treatment and if they're compliant to treatment. And then if they have been certified TB free, tell us which modality was used. Was it through a microscopy again? Was it through gene expert again? Was it through an X-ray, another X-ray that was done to certify them that they were free? I hope that helps in understanding. And then lastly, you get the patients who are getting the complications of tuberculosis. So for the complications of tuberculosis, we start with the easier one, extrapulmonary tuberculosis. In extrapulmonary tuberculosis, the most common one is TB meningitis, TB bone. And in TB bone and TB meningitis, remember there, the treatment duration changes. Then the other one is interstitial lung fibrosis. So in interstitial lung fibrosis, this usually presents like a restrictive lung disease. So when these patients do a pulmonary function test, how will it compare between it and chronic obstructive pulmonary disease? How will it compare? Okay, what will be the most prevalent symptom? Mostly they usually come in difficulty in breathing. But as I usually tell people, and this is how I was taught, if someone is saying that they've had difficulty in breathing for 6 years, and they're now finally coming to see you after 6 years, then I don't think that is what really brought them to you and they are pulling your leg. The question will be, why didn't you come the second day when you started presenting with difficulty in breathing? And once you start asking those pertinent questions, then it opens a world. You find that maybe it's progressively worsening difficulty in breathing, showing that there's something new that has happened, okay? There's difficulty in breathing in addition to other symptoms. Maybe they've started having a weird chest pain. Maybe they've started having swelling of their legs and their legs, okay? Yes. So for the respiratory history, again, the five in the HPI, the 5 things never change. The symptoms, the associated factors, the important positive, the important negatives, they never change. The severity and the risk factors. But I'd want you to clerk our occupational history, and maybe we can finish with that. How do I take an occupational history? Now, for example, let's think of let's not think of doctors, because I think doctors were in pipelines of school through your life. You're in school for majority of your lifetime. Let's take, for example, someone who starts as a middle worker, someone like an essential worker. I'm a number. So they finished school in 2016. That is when they finished class 8. And then they went into high school. And then the high school, unfortunately, they dropped out in Form 3. And then in Form 3, they picked up a job. They started with touting. So they are the numbers. They're not the conductors, but they're people who try to get people to climb a certain matatu in town. That was their first job. And then because he's a hard worker, he was able to gather all his resources. And then after that, he got a work in an industry. So he started going to an industrial job. In the industrial job, he was dealing with packaging goods. and the goods were usually maybe the leather tanning. So he was in the sides of packaging. But because he was a hard worker, he managed to go into the management. And then after he got into management, another industry kind of picked up on him. And now he went to work into the cement factory, still as a manager in the industry. Because he's been dealing with money, he's been dealing with people, his human resource is good. And then, he's gotten connections now. After that, he left that. And then he got maybe a job in the Ministry of Labor. And in the Ministry of Labor, it's an office job, it's a 9 to 5, yada yada. He just works there in Nairobi. And then now, when you're meeting him now, he's now 50. He's retired. And now maybe what he will tell you, I'm a farmer. So when you ask the occupation, you'll be like, Doc, James, what do you do for work? Be like, I'm a farmer. I've been a farmer for the last 5 years. The problem with that is now maybe you start thinking of the organophosphates, maybe the fertilizers, the birds, maybe he's driving birds, and those are the risk factors you're looking at. But you are forgetting the fact that this person has been working for the last 40 years. And in these 40 years, what has he been exposed to? So in the occupational history, always do it in a chronological way. So ask the patient, when did you get your first job? Where was your first job? What were you doing? And then when you do that, they kind of remember and they can always place things in totality. And with that, it can also help you to guide on it. Yes. So that's how best to take an occupational history. So do it chronologically. And please, for the respiratory histories, the risk factors are crucial. Okay. So for the risk factors that are crucial, maybe we don't have time, but I will highlight that the autoimmune diseases such as systemic lupus erythematosus and rheumatoid arthritis. What are their risk factors per se? And then you have the infectious diseases such as the pneumonias, the TBs. What are their risk factors? Then you look at COPD. What is the risk factor of COPD? And then you take something like the interstitial lung diseases. What are their risk factors? And then lastly, you take something like lung cancer. You are like, okay, what could be the risk factors for lung cancer? So the risk factors are very, very important. I don't think I have much else to add about how to take a history in resp and renal, but I hope I've helped you. My parting words is, in any history, in any HPI, remember the 5 buzzwords: the symptoms, important positive, important negatives, the risk factors, and the severity. And lastly, as a word of advice for the people who are having exam this week, actually, Majaliwa, is, if you feel you'll forget, my trick was always to write those 5 segments down, so that when you're going through and you're talking to the patients, you'll always be like, oh, I have not done the risk factors. Oh, I have not asked about severity. Oh, my important negatives, my important positives are not adding up. They're not beefy enough. Or in the symptoms is detail. Okay? Detail. So maybe I didn't take this detail. And with that, I would like to end my session. Thank you so much for coming.